presenting oncotherapeutics and role of echocardiography. In last 20 years, life expectancy of patients with cancer is steadily improving. There is a large group at risk of treatment-related complications. Earlier, what used to happen, because of the chemotherapeutic drugs, patient used to die and we did not have follow-up of patients who got improved because the number of patients improved were very less. My own mother died of chemotherapy within 1 month of starting the chemotherapy. It is very ironic and tragic that the drugs which cure the cancer may also kill a certain number of patients with cardiotoxicity. What are the ill effects of chemotherapy? Clinical heart failure in 1 to 5%, and majorly it is asymptomatic LV dysfunction which occurs in 5 to 20%. Other things which can happen, diseases which can happen are hypertension, pericardial effusion, bundle branch block, Takotsubo cardiomyopathy and myocarditis. This is the first case, 61-year-old male with type 2 DM and class 2 dyspnea. He was diagnosed as non-Hodgkin lymphoma, left cervical region. In 2017, baseline echo was done. Local resection was done, followed by CHOP therapy. 3 cycles were given. He became symptomatic, that is, he developed symptomatic heart failure after 3 cycles, and echo was done and confirmed the finding. And then chemotherapy was stopped and radiotherapy was given. In between, patient remained in follow-up with the oncophysician, and last time he came to us on 4th May 2024. We don't have any data regarding troponin or anti-proBNP because the patient was in follow-up with the oncophysician. So this was the baseline echo. You can see EF is absolutely normal, 61%, and global longitudinal strain is 19.3%. You can see this. When we do echo in such patients who are to undergo chemotherapy, what is the aim of echo? It is for detecting high-risk subjects. High-risk subjects means those who already have LV dysfunction, cardiomyopathy, ischemic heart disease, and early detection of CRCT, and treatment of CRCT and follow-up. For all these, following the ejection fraction and to rule out heart failure, echo is required. Baseline and periodic in treatment and after treatment echo has to be done for assessing the cardiovascular risk. What do we see in such patients? We see clinical profile of conventional risk factors and ECG, echo and troponin or BNP or anti-proBNP. These are the things which we do in the follow-up of such patients. The recommendations, ESC guidelines 2022, guidelines for recommendations for cardiac imaging modality in patients with cancer are echocardiography is recommended as first-line modality for the assessment of cardiac function in patients with cancer. And 3D echo is recommended as preferred echocardiographic modality to measure EF. GLS is recommended in all patients with cancer having echocardiography if available. Plan for this patient after biopsy was 6 cycles of combination chemotherapy with cyclophosphamide, doxorubicin, vincristine and prednisolone, that is CHOP regime, and combined with 6 doses of rituximab given every 21 days. But after 3 cycles of CHOP therapy, patient developed clinical heart failure. He became symptomatic, and you can see the echo. LV dysfunction is present, and mild pericardial effusion is also present. CHOP therapy means cyclophosphamide, hydroxydonorubicin, oncovin and prednisolone. It was combined with rituximab. Rituximab is a recombinant anti-CD20 antibody that has emerged as effective therapy for non-Hodgkin lymphomas and other B-cell malignancies. One of important thing about it is, it does not increase cardiac toxicity. Now, what is cardiotoxicity? How do you define it? What parameters you see? You have to see development of clinical heart failure, EF, fall in EF below 50% if it was previously normal, or fall in EF more than 10%, and global longitudinal strain fall by 15%, or development of pericardial effusion without right heart failure. Chemotherapeutic toxicity can be acute, subacute or chronic. It is acute or subacute if it develops within 2 weeks of start of chemotherapy, and it can be chronic, early chronic and late. Early within 1 year of stopping the drugs, and late after 1 year of stopping the treatment. So this is the ESC 2022 guidelines recommendation for baseline risk assessment and monitoring during the anthracycline chemotherapy in first 12 months after therapy. Baseline echo is recommended in all patients with cancer before anthracycline therapy. In adults receiving anthracycline therapy, an echo is recommended within 12 months after completing treatment. High and very high risk patients, echo is recommended every 2 cycles within 3 months after completing treatment. In moderate risk patient, additional echocardiography should be considered after a cumulative dose of more than 250 mg per meter square of doxo. In low risk patients, additional echo may be considered after a cumulative dose of 250 mg per meter square of doxo. Main objective of echo in such cases is minimize unnecessary interruption to cancer treatment and defining and refining cancer therapy related cardiovascular toxicity. So in this patient, CHOP was interrupted after 3 cycles after seeing the echo. Radiotherapy was given, treated with anti-heart failure therapy since 2018. He underwent coronary angiography in October 2023 for a possible non-Q anterior wall MI. Repeated echoes were done, and they continued showing the LV dysfunctions, both systolic and diastolic. This is the angiography of this patient. You can see normal dominant RCA and ostial 75% stenosis in OM2 and 50 to 70% in D2, which the LV dysfunction, amount of LV dysfunction is not explained by this because they are small branches and supply small areas. There is no involvement of the main vessels. So this is the echo which we did last on the 4th May 2024 when patient came to us last time, and EF was 40%, GLS 11.3%, and you can see non-uniform involvement of LV in bullseye. So summary in this case is residual chemotherapy related toxicity even after 6 years. Patient is on ACE inhibitor, beta blocker, MRA and dapagliflozin, continues to have class 2 dyspnea, and non-critical CID is not likely to explain the cause of LV dysfunction. Now something about cardiotoxicity. It is of 2 types, irreversible or reversible. Type 1 is irreversible or partly irreversible due to anthracyclines, and it is dose dependent. And type 2 is reversible with the treatment, and it is dose dependent. How do you differentiate between this? Type 1, in this there is cellular death. Damage starts with the first administration of the drug, and it is proved with the biopsy, and cumulative dose is more important. And permanent damage occurs, there is no recovery or partial recovery only occurs. The risk factors are combination chemotherapy, prior or concomitant radiotherapy, late age, previous cardiac disease or hypertension. In type 2, There is cellular dysfunction, not cellular death. No typical anthracycline-like biopsy changes. No cumulative dose related changes seen. Predominantly reversible. And risk factors are prior concomitant or concomitant anthracycline or paclitaxel, or late age, previous cardiac disease or obesity where BMI is more than 25 kilogram per meter square. So chemotherapy can cause myocardial diseases, myocardial dysfunction, pericardial dysfunction and conduction disorders. There are various chemotherapy drugs which cause cardiotoxicity, and these are anthracyclines, alkylators, antimetabolites, antimicrotubules, monoclonal antibodies and cytokines. Important factors to be considered to avoid cardiotoxicity are the dose of anti-cancer drug administered during each session has to be monitored properly, and cumulative dose has to be seen. Schedule of delivery, route of administration, combination of the drugs given and the sequence of drug administration has to be seen. Now there are things you have to see on the in echo and MRI, and both on the right side and the left side, these are various parameters you can see there which have to be seen, for ruling out the chemotherapy related cardiotoxicity in echo and MRI. And this is another way of monitoring the patient with the chemotherapy, how you have to monitor. Low risk, moderate risk, high risk, in all you have to do ECG, transthoracic echo and BNP. BNP has to, these are the things which you have to in baseline you have to do in all, and in low risk patients you have to do every second cycle BNP and transthoracic echo after fourth cycle, and then at the 12 month after treatment. And similarly in the moderate ones you have to do BNP after every second cycle in the at the end of fourth cycle and at the end of 3 months of stopping the treatment. And echo you have to do every in the fourth cycle and then at the 12 months after the stopping treatment. And in these severe cases, high risk cases, you have to do BNP at each and every chemotherapy, and transthoracic echo you have to do every second cycle and in the fourth cycle and the after stopping the treatment in 3 months and 12 months. This is another short case which will I finish fast. 63-year-old obese female, diabetic for 20 years, had MVR in 2013 and then 2018. Bileaflet mechanical valve with TVR was done. Normal angiogram was done, which was done in 2018. Diagnosed as lung cancer with bone, liver and cerebral metastasis. Was on 5-FU. Previous hospitalization was on 22nd November 2021 when she stayed till 3rd December. Again she presented on the 5th December with tonic-clonic seizures, and ECG was done. Echo was performed on 6th December, which I will show. And troponin was 0.05 and BNP 448. This is the picture you can see. On 6th December, you see the regional wall motion abnormality. Whole of the upper and apex, upper and middle segment, apical and middle segments of all walls are not moving. And in the echo of 8th December, slightly improvement is there, and on the 10th December, it has completely improved. So this is Takotsubo cardiomyopathy which has occurred. This patient was given rituximab. There is a paper showing Takotsubo cardiomyopathy in cancer patient. Most likely the drug which can cause it is rituximab. And the summary of my presentation is oncologists and cardiologists should better collaborate in the assessment of patient receiving potentially cardiotoxic drugs, and therapy decisions involving the same patient might potentially mean exchanging one fatal disease with another. Thank you.